Good morning, not good afternoon, everyone. Welcome to our community oncology session this morning as part of our spring online school. We're really pleased you could join us this morning. Just a few quick bits of housekeeping before we get going. We've got the chat function available if you want to talk to the team, if you've got any sound problems or anything like that. And we've also got the Q&A open. So please type any questions you want to pose to the team into there and we'll make sure they're answered either as we go along or at the end. We're all working from different locations, so please bear with us if there's any technical problems or interruptions. But that's enough from me. I'm going to hand over to the fantastic Dr. Fiona Rawlinson. Thank you all.
Great, thank you very much, Charlotte. And welcome everybody. I'm just going to share my screen. We are very excited about this session today. And just perhaps to give you a little bit of history for kind of why we've put this session in today. And it's arisen from the Community Oncology series that started off in March the 20th, 2019, when we did a one-day at over in the Whitchurch Rugby Club covering case-based discussions on a cancer journey for a patient through diagnosis, through preparation for treatment, through the different treatments. And it was a really interprofessional audience. We had paramedics, we had GPs, we had nursing teams, we had people from oncology, from secondary care. And actually we were brainstorming bits of how to make that oncology journey any smoother, including thinking about elderly care and thinking about the challenges, particular challenges in trying to make decisions for more elderly members of the population. So there were some great light bulb moments for people as a result of that. So we thought we'd do it again. So March the 18th, 2020 was the plan. Same kind of setup. Yeah, but except it didn't quite work. And so this was one of the first events, sadly, that had to be cancelled because of coronavirus, because remembering this time last year or March last year, it was a very tense situation. But our quest for getting that oncology knowledge out there, talking, thinking oncology from all different perspectives, that was not dimmed. In fact, COVID has made that more important than ever. So one of my colleagues who you're going to meet in a minute, Elise and I, we worked with another colleague in general practice to create some podcasts around, some of it was around managing cancer during the coronavirus pandemic. And we were able to deliver 5 funded webinars, free webinars, which are available on the YouTube channel. So the role of understanding cancer in patients is even more important than ever before at the moment. But as part of our discussions, we then really realized that there is a moment. And so we were really thankful for Charlotte and colleagues in the CPD unit to be able to think about looking after our elderly members of our populations and what does cancer mean to them, how can we help our decision making, which is quite conflicted at times, really thinking about what is best for the person in front of me. So that's how we came to be where we are today, and it's really great to see people here. We'd really encourage you to use, we've got 3 cases. So on the panel are going to be Dr. Elise Lang, who is one of our GP colleagues, Dr. Mick Button, Dr. Allie Shipp from Velindre, and Dr. Dafydd Brooks, who is one of the care of the elderly physicians from the Heath Hospital in Wales. So we've got 3 really key groups of people to think about the decision making. I don't know whether we're going to have time to answer all the questions that you might pose in the chat, but please put them there, because if there are themes running through the things that you're asking and we haven't been able to answer all of them just because an hour is not very long and I've already spoken for 5 minutes, then we may well be able to develop a further series of CPD short courses, days, hopefully when we can all be together again, just really to try to get the best for our patients. And so I think, without further ado, I'm going to just say what we felt the aims of the session were. We're going to just really highlight some of the complexities of decision making in elderly patients and describe some strategies to help that decision making. What would be helpful, though, before we really get going, is to just get an understanding of what backgrounds you're from, for those of you who have joined us. So I wonder, Jess, can you possibly put that poll up just so that we can see where you're all from? And please forgive me if you're other. If you tick other, you are just as important as everybody else. It's just that we're limited with the number of options that we can give on a poll on Zoom. So it'd be really helpful just to know who's here. That's great. And what does it look like? Fantastic. So if you are other, would you feel able to put your background in the chat? That would just be absolutely amazing. Thank you so much. So without further ado, I am, when my slides wake up, and all the cases that we have together are based on real people. So this is the case we're going to discuss first. And I'm sure many of you have seen Mary's in your work. She's an 87-year-old lady. She's got advancing dementia, being cared for at home. In lockdown, her daughter helps to shower her, notices a fungating breast wound. Mary's not clear how long it's been there, and her family seek a GP consultation. So really just thinking about management. Are we going to refer her or not? What's the oncology approach if we do? And if she's got mental capacity for decisions and says no, what then? She's got advancing dementia, so we know that her capacity is a little bit under question. I'm actually going to stop sharing my screen for a moment, just so that we can really think about this. So she's 87, she's got advancing dementia, and she has a fungating breast wound. I'd like to bring in Elise first. From the GP perspective, Elise, start the discussion. What are you thinking about?
Morning, everybody. It's not an uncommon case, this one. We've tried to pick cases that are common to different, parts of our roles. And in general practice, it isn't uncommon that someone identifies a skin lesion, a breast lesion that has gone unnoticed for some time, perhaps covertly, by the patient themselves, not wanting to raise it because of other situations at home. And when you get this, it's a really difficult situation to manage. It's hard to know where to start. Certainly my head's all at sea when I have to see this patient in terms of what their agenda is, both in terms of the patient's agenda, but also the relative's agenda, and also my own agenda. And this is where I feel, in primary care, I'll be honest and explain some of the feelings that I have. My first and foremost feeling is it breast cancer? Is that what we're looking at? Is this breast cancer? I'm no pathologist, I haven't got a tissue sample, I don't know, but it's a really unpleasant, smelly, fungating wound, which from previous experience would suggest it's probably breast cancer. But is that enough? Do I need to refer this patient onwards, for further diagnosis and biopsy? And it obviously comes down to patient choice and family choice and sort of that community discussion. But I never quite know whether I'm in the right place to make that decision for someone. And there's a number of sort of little voices going on in the back of my mind at that time. Obviously, if the family are adamant and they say, I really don't want mum referred, she's much better off at home, I understand it's probably breast cancer, but we wouldn't want her referred, I'd like to involve the palliative care team, and they go down that route, I'm comfortable to an extent, with obviously comfortable with supporting them at home and going down that way. But it's when they say, what treatment options are there, and what would happen if mum was referred, and I'm not really the best placed person to decide. And a number of my thoughts really reflect around end of life care really for this lady, because she's got advanced illness with her dementia, she rarely goes out the house anyway. What quality of life, what sort of level of active treatment should we be offering this lady? And it certainly isn't my position to decide on that. But the other sort of worry in my mind is, what if we don't refer her? Is it okay to write breast cancer on the death certificate down the line? Was it diagnostic that she had breast cancer just because it looked like it? And is that helpful to her family members? I worry that, if this is breast cancer and I haven't referred her, is her daughter at risk of having breast cancer? Was her granddaughter at risk? If they got something at the age of 30, should I have had a tissue biopsy on grandma? Those kind of thoughts play in my mind. Clearly, I want to try and avoid her going into hospital unnecessarily and have, prolonged tests and things. But where in the community can we say is the best place for Mary? Should she be referred for some basic tests? Or should she, not be referred, and we ask for the colleagues like Dr. Fiona Rawlinson to see her on a home visit with the support of the sort of community palliative care team? And to be quite honest, I don't think there is a right or wrong answer here. It is obviously case-based, and each individual case should be reflected on its own merit, and obviously keeping the patient at the centre of those discussions. They may previously have written an advanced care plan that's available that would say how they wanted to be treated in this situation. But I just wanted to open the door on a sort of difficult consultation I would find in primary care, and ask my colleagues, who are far more expert than myself, in what they would recommend. And so from here, I would ask probably one of the doctors in our local cancer hospital, which is Velindre Cancer Centre. So Dr. Allie Shipp's on the call, and also Dr. Mick Button, and I'd just like to pass to them for their opinion on what they see, if a letter came into the breast MDT, if I was to write a letter to say, I've got this lady at home, we haven't got a tissue biopsy, should I write a letter to you, or what's best? Allie?
Yeah, there's a lot to unpick there, and as you say, a lot of it is going to be on a case-by-case basis. But I would say that doing a referral doesn't necessarily mean that the patient needs to come to hospital. And if you are needing a bit more advice and support, that referral might be sending photos, having a conversation rather than appointment, and we can work and be pragmatic. Clinically, it sounds like the diagnosis might well be breast cancer. The way that we'd prove it would be doing a biopsy, but that's going to involve a trip to hospital. That might not be right for this patient. And then there was a bit of a conversation about what oncological treatments are there, which is obviously something that I know a bit more about, and I know a bit less about the community kind of side of things. So if this is a breast cancer, the likelihood is it's an estrogen receptor positive breast cancer, which can be treated with hormone therapies. I think we're probably all agreed that chemotherapy here is the last thing that this lady needs. She doesn't sound fit enough for it, and that sounds like it's going to cause a whole range of problems. Endocrine therapy is basically tablets to block estrogen in the context of a tumour that grows well in the presence of estrogen. So that's things like tamoxifen and letrozole. They come in tablet form, and they're generally quite well tolerated. Being pragmatic, and particularly in the situation given where we're in lockdown, there's an argument to say, is it worth giving some endocrine therapy in tablet form where she is, not bringing her in, not doing a biopsy, because it might help with managing that fungating wound. It might improve it, cause it to regress, and caring for a fungating wound is really unpleasant. So I think I think that's something that we could definitely kind of consider. And I'd be comfortable making that decision to say it's likely to be ER-positive breast cancer. The risk of doing that is low. The tablets are well tolerated and there's a potential benefit there. So I think it is a bit about thinking about the kind of practicalities. I guess the other thing as an oncologist that springs to my mind with a fungating kind of skin lesion is, would radiotherapy be helpful? I'm a medical oncologist, so I am going to pass over to Dr. Mick, who's a clinical oncologist, to talk a little bit about the technicalities there.
Thanks, Allie. I mean, it's a really good case which we do see, sadly probably too often, and I think a lot of people in healthcare where we might see a bit of a surge of these, similar difficult cases as lockdown opened up and people start going out and seeing relatives more than they have done before and finding things, and that might be part of a post-COVID surge. I mean, obviously every case has its own individual specifics, and this case has a lot. But in terms of general principle, I think Allie's point of having a conversation with the team in the hospital isn't a burden to the patient, because we don't want to give a burden to this patient or her family. And, we do have multidisciplinary teams who can discuss cases. And, in terms of your thought, Elise, of decision making and labeling and future risk maybe of that, sharing the responsibility of that with a diagnostic team in a hospital can be done with no impact on the patient, because we can have that team discussion and support in terms of a body of clinicians agreeing that something might well be breast cancer and therefore a treatment plan based on that would be reasonable. So we're sharing the burden of that responsibility and taking it away from an individual who may have concerns about making that decision themselves. And that really doesn't impact on the patient at all, because we can do that without them physically coming whatsoever. In terms of the patient and their relatives, I think communication really important. Oncology centres are open. We are here and we are here to support and help both patients, relatives and colleagues. We can have conversations with clinical colleagues very easily. With consent, we can talk with relatives. Depends what's been agreed in terms of powers of attorney and care and things like that. We're doing a lot of consultations virtually, either by telephone or video. So again, we can do things without the burden of a patient physically coming to hospital. I think documentation is important here, in terms of the pros and the cons of different approaches. So it's, it's clear. I think the recent Montgomery case is in our mind in terms of consent for either doing treatment or proposing the options not to have treatment and what those look like, some of the uncertainties and the risks and the benefits. I think something like tablet therapy for a patient like this might be something which could be explored. I think probably with oncology input for that, I don't think anyone's expecting a primary care practitioner to start primary endocrine treatment for a diagnosis of breast cancer in the community. We'd want to share the responsibility of that. And that could be therapeutic for the patient and diagnostic, because if the breast mass shrinks, it kind of tells you what it is as well. I suppose one thing in my mind is, well, you can see the breast mass, but what else is going on under the surface? I think you need to think that thought, but in this case, maybe not do any investigations, scans and things like that, because the treatment is going to be overwhelmingly based on her quality of life and symptoms. And you understand that from listening to the patient and looking at the patient, not from doing scans. So I don't think we need to do scans in terms of looking at is there spread anywhere else. Radiotherapy, in this sort of case, that endocrine treatment might be all we need to do. So you could start endocrine treatment, see what happens. It could dry things up really nicely. And that actually could be the palliative treatment that she needs. Radiotherapy is certainly possible if there's ongoing problems, or if it's a different situation, say, where there isn't an endocrine treatment. There is a burden with radiotherapy, though. That definitely does involve coming to hospital. There isn't a way of doing radiotherapy virtually, and I suspect there probably won't be. Fiona's just sharing a picture of one of our radiotherapy machines, which, you know, people on the meeting may not have ever seen before. So it's not particularly claustrophobic. It's not like an MRI scanner. It's a big open room that the head of the machine kind of swings around. We've produced some videos, which I can share the link at the end of the meeting if you want to have a look of what it's like from a patient perspective going into a radiotherapy treatment. Usually a patient would need to come to a hospital for a planning scan or a planning visit, so we can plan out the radiotherapy beforehand. So it's usually a minimum of 2 visits to hospital with, you know, transport and difficulties and things like that. And a big thing here is this lady's dementia, and that can be very different for different people. But what's really important in radiotherapy is the kind of the consistency and reproducibility between the planning and treatment. So we have to be absolutely certain that the patient's in the same position, that they'll cooperate, that they won't move. And although we've got Dot here, one of our radiographers, with the head of the machine kind of pointing at her, this is when the machine's turned off. So when the machine goes on, all staff need to leave the room. So this lady is going to be left on her own on a treatment machine. And on the right-hand side there, you can see the couch. It's hard, and it has to be hard because if it's soft and comfortable, movement is allowed, and then you lose the reproducibility. And there are no cot sides on that couch. We can do things to support patients, but if we're worried about safety here, that the patient might not lie still for a few minutes while the staff are out of the room, the last thing we want is the patient to move, have treatment to a different area, or even worse, you know, fall off that couch and have an injury. So the practicalities here in terms of how safe and appropriate a treatment like radiotherapy is, it's very individualized, but I think that would be, you know, something to chat through with an oncologist who knows the details about radiotherapy. But we just wanted to show you a picture and talk it through. So, you know, we were sharing just a bit of information, because in terms of decision making, just having that background information is maybe helpful.
Thank you very much, Mick. And I wonder whether, Dafydd, can we bring you in now, just with your perspective really as a geriatrician? Is there anything else that you will be thinking about?
Thank you. So I think from my point of view, we all assume that the breast cancer is a significant problem for the patient, which it might well be. But we also know that it was discovered by the daughter when she was washing the patient. And so it might be that this cancer isn't actually having that big an impact on Mary. It certainly has the potential to obviously shorten her life, and down the line could cause lots of problems like pain or distress from this malodorous fungating tumour. But it may be that at the moment she's quite symptom free. And whenever we decide how we're going to pursue something, we have to try and balance the risks, balance the harms. So I think sometimes the hardest thing in medicine is to do nothing, but sometimes that can actually be the right thing to do. It's not necessarily doing nothing. Sometimes it can be a sort of a watchful waiting approach. We know that as time goes by, it might be that she develops other symptoms, and I think as Dr. Button suggested, there might be a question of what else is going on. We know that there's a fungating mass, but is there a potential for it to be brain metastases or cord compression developing in the future? So it's important to always bear that likely diagnosis in mind, because if the patient develops new symptoms, you might want to pursue certain investigations as a result of that. But I don't think we necessarily always have to do something just because we can. There are risks, as I said, there in not pursuing things. So it is really a balance that we have to strike. And when it comes to this, I always just think of the 4 key ethical principles: beneficence, autonomy, justice, and non-maleficence. So what we don't want to do is to cause harm here by over-investigating. And that's very much a patient-by-patient situation.
Dafydd, thank you so much. So we're going to bring Mary to a close and move on to our case 2 in a moment. But just sort of giving you a flavour, there's the themes running through our communication, balancing up the benefits, burdens, but also thinking about the implications in different situations. You know, if she stays at home and there's a bit of uncertainty, what would go on that death certificate. And it's about really collecting as much fact as possible, I think, around the possible treatment options, the possible impact of that treatment. What are Mary's wishes? Has she written them down? What does her daughter think? It's bringing all of those together. And because we are all unique people, there is no one size framework that's going to fit everybody. And I think sometimes just allowing ourselves to understand that sometimes these situations are as complex as they appear, but by using ethical principles, by using listening, by using communication skills, but by using our wider team. So thinking who might be able to answer this question, rather than send somebody off to clinic or seek lots of scans and things. Let's just pause a minute. Let's think, who can I ask? Because that information might just help inform the decision making. And of course, the other thing thinking about is sometimes these sort of conversations take more than one conversation. There may need to be a giving of information and then a pause before going back and collecting the themes and making what would be an appropriate case for Mary. Any other reflections, etc.? Please pop them in the Q&A, pop them in the chat. Preface them with Mary, because we are just about to move on when my slides decide to come up. And we're going to move on now and talk about John. And I'm sure many people have encountered John either from the community, as a GP, as a district nurse, as a practice nurse, as a paramedic, as a palliative care team person. And of course, working in secondary care, you will have come across John. He's 92. He's been admitted to hospital following a fall. And in that workup, we discover he has a large mass on his chest X-ray, and his team are considering his management. So I'd quite like to bring Dafydd in here as the first port of call. Dafydd, what would your thoughts be on John?
So yeah, this is a very common situation we find ourselves in secondary care in particular. And I always think that the first question we have to ask is not how do we investigate this further? It's actually, have we told the patient what we found? It's amazing how often we seem to forget that patients need to be aware of what's going on to help make informed decisions. Now, it's important, although he's 92, he doesn't seem to have any comorbidities, and we should always assume that patients have capacity, and so should always be actively involved in any decision-making process. We can only really consider assessing somebody's capacity if they actually have a disturbance of mind or brain. And so without that, the assumption is this gentleman should be involved in all decision-making processes. If there was some cognitive impairments and we were assessing his capacity, it's important that we've given him all the information we can to help him make a decision. Sometimes that means having family members come in to help somebody with making that decision, which at the moment is a bit challenging because of COVID, but it's not impossible. The other thing that I think that's really important actually is that when we discuss these cases with patients, it's important not to use euphemisms. So it's not uncommon to hear a patient say, oh, it's okay, it's just a shadow on my lung. I think it's really important sometimes to say this is a potential cancer, because if we're not giving them the correct information, then we're not enabling them to make an informed decision about how they proceed. In hospital, we're lucky that we have lots of different organ-specific specialists. So while as a geriatrician, I might be happy looking after aspects of John's care, such as frailty, I might not be the best person to make a decision about how we would investigate this mass further. So we might be able to refer to, for instance, the respiratory team locally. We also have the advantage of having an acute oncology service in this hospital, which acts as a liaison between the sort of secondary care and our oncology services. And that can be really useful when you're not entirely sure what treatment options would be available for a patient if this turned out to be a malignancy. Because what you don't want to do is to give inaccurate information to a patient, so promising him treatments that he would never be fit for, because that obviously will have an impact on his decision-making process. I think I'm not the best person to talk about how we would further treat or investigate this gentleman. I don't know if Allie or Mick have anything they want to add.
Thanks, Dafydd. Yes, Allie and Mick, what from your perspective, how would you be thinking about this situation?
So I think Dafydd's point there about evolving acute oncology is really important, and that probably is a bit of a practice shift in recent years. I think historically we were often not getting involved until there was a tissue diagnosis, but actually in most of the hospitals across Wales now we do have an acute oncology service who will see people in this situation. And that can be really useful, partly for a bit of support for the patient, but also for them to feel like they're accessing specialist cancer services. Cancer is a scary word, and often people come and say, I want to see a cancer specialist. And so having that link can be really useful in supporting this, supporting from the early part. If we're thinking this is a lung cancer, lung cancer has become much more complex over recent years. I know Mick treats lung cancer as a specialist, so I will bow to his expertise here, but there are quite a lot of factors to consider in what potential options might be for him. We don't have that much information here. We know he's 92 and he's had a fall, but we don't really have a feel for how fit he is, what his comorbidities are. Those things are going to be important when we're thinking about what treatments might be available. But yes, there are complex decisions here, and I will ask Mick to speak a little bit more about the complexities of lung cancer and a kind of new diagnosis.
Thanks, Allie. And lung cancer has changed dramatically over the last 5 years in terms of treatment options, and you may have been in some of our sessions and discussion around that. We certainly have more things available now than we had before. I'd agree with the points that have been made of, absolutely making sure that the patient is at the heart of discussions and decision making with open and honest communication appropriate for his situation. I think AOS probably does have a role here in terms of involving the acute oncology services. We don't know if this is a lung cancer. It could be a metastasis from somewhere else. There'll be lots of things in this in terms of how fit and healthy he is. What was he like before this fall? What was the cause of the fall? Judging somebody in terms of fitness when they were an inpatient in hospital is never a good thing. So I liked Fiona's idea of, you might have an initial conversation and then meet again later on. I'd want to look through the previous records, looking at comorbidities, health problems, previous imaging. Was there an X-ray a few years ago? Is this new, or has it been there for a long time? Is it slowly growing? What symptoms is this mass causing? If it's asymptomatic, it might not need any direct treatment, but if he's got chest pain or hemoptysis, we might go back to that thought about some radiotherapy or something. I think in terms of principles, involving the patient, making sure the patient and the family are aware if appropriate, if he's got family and if he's okay with that. We do look at sometimes giving chemotherapy to anybody who's fit enough, regardless of age, really. I think it's very difficult to give chemotherapy without a good tissue diagnosis. So that would require a biopsy, I would have thought. But if it's symptomatic and the agreement is a palliative approach with some radiotherapy, then we often can do that on a radiological diagnosis, a bit like Mary in the last case. We don't need a tissue diagnosis for that necessarily. We don't have to get on with that immediately. There's that kind of, we can do something now, we can agree to do nothing, or we can say, well, let's go for a middle ground of let's keep a watch on this and see how things develop. So we could organise follow-up and then another X-ray and another review maybe when he's back at home to assess fitness and symptoms and things like that. A bit like the breast cancer situation, there are some patients with lung cancer who are very well treated these days with tablets, which are pretty well tolerated. They're not like chemotherapy at all. It's a very small subset of lung cancer patients, though, probably about 5%. So if you're thinking biopsy, look at tablets if the numbers are getting very small, and the risk of a biopsy certainly is quite high. There's pneumothorax and bleeding and things. So you have to be honest in terms of the risks and benefits of embarking on investigations and involve the patient in that as to whether they want to do things or not. But there might be an option for a treatment which is very well tolerated with minimal morbidity and minimal burden to the patient, which could have a very good symptomatic or even prognostic benefit if the patient wanted to pursue that. And that's a very individualized decision, which, exactly as Fiona says, is not something that you necessarily make in one go. You often say, let's have a chat now, come back in a few weeks' time and we'll have another conversation and see how that initial decision sat with you. And then things can always be changed in light of further information or how things feel.
Thanks, Mick. Thanks, Allie. And that then takes us back as well to Dafydd's point, which is actually involving the patient in decision-making, involving John. And with all that information, it is possible that John himself will decide, on the basis of the information, understanding his mental capacity, he may decide that he doesn't want to have any treatment. But the fact that we've got accurate facts, we've got accurate information, we've checked his mental capacity, that's really important and central to his management. Elise, can we bring you in on this discussion now? For example, as his GP, what would your perspective on the situation be?
Yes, thanks. And a really interesting discussion so far. I think, what resonates from primary care's perspective is the great need for secondary care colleagues to let us know what they found and what they've told the patient in a timely manner. So it's not uncommon that this patient might call us the next day, or his wife might call us and say, oh, have you heard the news about John? And we're kind of scratching around trying to find out what news about John. And you don't want to be the one that sort of says, oh, no, it's quite difficult. And all the opposite, when you've got a letter that says, it's been in with a fall, large lesion on chest X-ray referred to oncology. But what does he know? And was referred to oncology a request for me to do it, or has it already been done? The clarity of what's happening needs to be passed to primary care. It's fundamental and it needs to be done quickly. Because it's not uncommon then I might get that discharge summary, and one of us in the surgery is likely to know John quite well, or at least the family. He's 92, he's going to have been in and out more than likely in the last 20 years, and we will know him. And so we'll have some rapport that we can work on, but it's nice to know how you lead in on that call. Oh, hi, John, I can see you've been in hospital, what's been happening, and let him tell you a bit, explore his understanding. And it might be an opportunity to offer a sort of face-to-face consult in whatever format he finds most comfortable. He may want to avoid coming to another medical setting, particularly in COVID, so we can do that as a video call. It may be that we do it via home visit, or bring him into the surgery if he would like to come and just discuss what's his understanding and of all that information he's been told. And it may well be that we don't know any more than he does, and we certainly don't have the expertise of Dr. Button and Dr. Shipp, to be able to say what's the best option here. But we can just understand what he needs and try and ask the questions and advocate for him. If he says, oh, I just really want to know a bit more about the radiotherapy, we can link up and join the dots a bit. And it's really useful that we've opened the door to him and given him a point of contact in the practice and a knowledge of who to ask if there's other problems. And a lot of our nursing team will do that as well, with things like holistic needs assessments and cancer care reviews, and really understand what's most important to him. And actually that often leads on to conversations about advanced care planning. And that's not in any way to say that we are expecting his imminent demise, because it may be, as people have said, something that he's had for many years and actually not cancerous at all. But it's to just explore what matters most to John, what's important to him and his family at this time. Is that okay, Fiona?
Thanks, Elise. Brilliant. Again, so just bringing in the themes from the discussion. It's about thinking of our resources, thinking about who can we ask to get the most accurate information which will help John make his decisions, but then communicating across the team, trying to move beyond the barriers of the hospital wall, the house wall. We need communication to be effectively flowing between our care settings. Thank you. Let's move on to our third case, but I'm going to do something ever so slightly different now. And we want to talk about Jim, when my slides decide to let me talk about Jim. Go to sleep after a while. But I'd really like people on the call to have a think about this as well. So think about Jim, he's 80. He again had a fall at home. He fractured his right humerus. When he went in with his fracture, his PSA was found to be high, and an X-ray established the management of his fracture suggests it's a bone met. With a PSA that high, kind of the immediate working diagnosis is thinking, is it CA prostate? He's the main carer for his wife of 85. On the Q&A function, do people on the call just want to write what do you think the team need to be thinking about? He's 80, he's a carer, he's had a fall, he's got a break. We know his PSA is high. The team's considering his management. What would you want them to, what would you want the team to be thinking about? Write something in the open question bit on the webinar, and I'll shout out what comes. Oh, if I do that, I don't know if I do that. Maybe I'll put that on there. So any thoughts? Any thoughts? I'm going to stop sharing actually. There we are, that's a bit better. Right. So we've got started off. So it's a multidisciplinary team, needs to be involved. Yeah, he's there at the front door of the hospital with a fracture and a high PSA. And he's the main carer of his wife. Great. Yep, absolutely. I like that. He's a multidisciplinary team. Anything else? Just thinking about how we're kind of thing. So is he aware of the CA? We've got to think about the impact on his wife. Absolutely, absolutely. Great. Anything else? As family support. Absolutely right. So just thinking, he's there in A&E. What's happened to his wife? Who at the moment has been catapulted in? What do we know? What do we know about that? What does Jim want? Jim wants, but we need help for his wife. But he's got a big role in caring, hasn't he? And yes, what about the role of community palliative care? Can they help? Fantastic. Great. Okay. Let's go back to the slides. Great. Thank you for sharing your thoughts. It's a complicated one. Life's complicated, isn't it? It's not always easy. It's not always easy, this stuff. So, again, I'm just thinking, I think, Dafydd, can we bring you in first on this one, just from the geriatrician's perspective? How would you approach this situation?
Yeah, thank you. So, often in this sort of situation, we might not be directly involved with the patient when they first come in, especially if they've had a fracture, for instance. And often we can see them a day or two into the admission. And it's often quite interesting the way people are perceived. So unfortunately, it wouldn't be uncommon for Jim to have had decisions made already about him on the basis of, oh, he's got metastatic cancer and he's frail, and query fast track home or sort of something along those lines. So what I wanted to talk a bit about was how we assess frailty in these patients. I don't know if people are becoming more and more familiar with the term frailty. There's lots of long-worded definitions for it. The way I always think of frailty is a patient's bounce back ability. So if a patient were to sustain a sort of stressor event, like a fall or an acute illness, how badly does it affect them? And how long does it take them to bounce back to their normal level of functioning? Or in fact, will they bounce back to their normal level of functioning? There's different ways we measure frailty. A lot of people might be familiar with the Rookwood Clinical Frailty Scale. Certainly that was being used a lot during, well, prior to COVID, but during the COVID itself, the Clinical Frailty Scale was being used to make some quite significant decisions about patients of scenes of care, for instance. but I don't think it's always particularly well understood. If we take Jim, for example, Jim has fractured his right humerus. Most people are right-hand dominant, so I'm going to assume that this is his dominant hand. And so Jim may have gone from being somebody that was a carer for his wife, very fit and active, to suddenly being somebody that can no longer keep his house, needs help with bathing and dressing. And so if you were to do a frailty score based on Jim as he is when he's in hospital, you might say that he scores a 6, which is moderately frail. Whereas in fact, if we went back a week ago, he was well, he was a clinical frailty score 2. So using these numbers to sort of define how frail a patient is something I try to move away from, especially in the acute setting. I think in oncology, you might be more familiar with using terms like performance status rather than frailty, which are probably somewhat related, although not exactly the same thing. But in a similar way, he may have been a performance status 0 coming into hospital or prior to going to hospital, and following his fracture, no longer able to carry out any sort of work activities, and suddenly his performance status is 2. So what I think this shows that using these sort of scales, while it can help guide treatment decisions, isn't the be all and end all. And it's not a static, it's not a fixed thing, it's something we should revisit. With regards to him having metastatic prostate cancer, we know not every cancer has the same prognosis. And actually some patients, even with what appears to be quite advanced disease, can have a good quality of life for a good period of time. So what I always try to say to people is, if you're not, have all the facts available to you, if you don't know the prognosis of a patient, don't rush to make a decision about them. And it's important then to get your colleagues involved from maybe urology or the acute oncology service again, or speak to some more oncology colleagues. The other thing I suppose I would be thinking from regards to this gentleman in particular is, we know he's fractured a humerus. Are there fractures, are there other metastases elsewhere? And actually, are there interventions we might want to do while he's in hospital? So sometimes we get prophylactic pinning done of bone metastases if we think we could prevent further mobility in the future. So it's always worth spending a bit of time having a think about the further consequences. Yes, we've caught one problem, but there may be more we can try and fix while he's in hospital. Certainly, we would like to think about how his wife is managing at home. Although in secondary care, it's actually quite challenging for us to look after somebody that's not our patient. And so I think Elise might discuss that a bit later on. So I think my next step would be to involve the oncology team to try and gain some more information about what his prognosis is likely to be and how that can impact on our decisions. So I'll hand over to
Dafydd. I'll hand over to Mick and Allie. Any thoughts on that?
Here is your friendly oncology team on hand. There's so much in this that is not related to his cancer. And I think, it's really powerful to me that so much of this discussion has been the situation we're in rather than the cancer diagnosis, because I think that is the priority. Very similar to the other cases, we've got a presumed diagnosis of metastatic cancer. I think, bone mets with a raised PSA is likely to be prostate cancer in a man of this age, and often that's enough to make a diagnosis without a biopsy. Obviously, it's very individual, but even though treatment is with palliative intent, i.e. not hoping to cure a cancer in this setting, the prognosis of a man with newly diagnosed hormone-sensitive prostate cancer can be measured in years. So we may not be looking at end-of-life care at all, although that needs to be in the room when you're talking about things, because you can't guarantee things will go well. Thinking about a specific thing here in terms of his fracture, we often get referrals for palliative radiotherapy if there are lytic metastases and risk of pathological fracture. But a difficult thing that we need to discuss in that sort of situation is that radiotherapy actually doesn't help reduce the risk of pathological fracture. And if a bone is broken, you don't tend to get pain improvement with radiotherapy very much because you've still got a broken bone. So although it might be difficult, I think we do need to consider that orthopedic advice in here, particularly with his caring role, because if he's got his arm in a sling and we're going for conservative management, that's going to have a massive impact on him and his abilities as a carer. Allie, anything you'd want to add here?
Yeah, so I completely wanted to pick up on the points that you both made, which is actually in this situation, although he has got metastatic cancer, his prognosis may well be measured in years. And I think it is very easy to sort of say metastatic cancer, kind of end of life care, and actually metastatic cancer isn't one entity. And we don't expect everyone to know the prognosis of every cancers, but we are happy to be contacted and have discussions, and that's why we have an acute oncology service as well, and they can be a really useful kind of conduit in secondary care when thinking about those kind of decisions. And if they don't know the answer, they've got good contacts to people who do. So I think that's a really important point to bear in mind. And as you were saying, one of the first treatments we might think about here might be hormone treatment, and in a way the other stuff we can think about later. He's just broken his arm. It's going to take him a little while to recover from that. There are other treatment options that we use in prostate cancer. As Dafydd was saying, now probably isn't the ideal time to think about how fit he is for subsequent treatments. But if he has his arm pinned, or if he's in a cast and he has rehab and gets back home with his wife and we carry on seeing him in clinic, we can revisit that. And I think that's the kind of thing with all of them. None of these things are a one conversation and one decision situation. Things evolve, life evolves, things change, and it's a dynamic process, and that's important to just take kind of note of, I think.
Allie, thank you. I think that's a really important point, but how difficult it is to really use time to its best ability in the process-driven healthcare system that we work in, but for patient-centered care, it is really important. I'm slightly aware of time. I'd really like to bring in Elise now, just to sort of, so Elise, from your perspective as his GP, what are your thoughts?
Well, I think it's important to highlight the comments that have just been made. It is not an understatement to say in primary care we don't know a lot of detail about a lot of things, and so as Ali just said there, this chap's prognosis might be measured in years. It's really important you tell us that, because if we don't understand prostate cancer and have a prostate cancer with Mets, we may be very doing roughshod and coming in and or at least presenting like we are, and stopping non-essential medications, stopping statins and sort of reviewing what we're doing if it isn't clear to us that actually this could be something that he lives with and will die from something else down the line. So the sharing of the information is really important, and together with Macmillan, as you know, Fiona, we've been doing work on treatment summaries and prognosis terms that are used when a patient has a cancer diagnosis, and it just helps the level of understanding between healthcare professionals who are involved in treating this patient to be on the same page, because I think there can often be an assumption we are when we are within our own speciality, but we don't have the expertise of our colleagues who are also managing this patient. From primary care's point of view, there would be tremendous worry for both Jim and hopefully his wife. Hopefully we know that he is a carer, and hopefully know that there's a vulnerable patient left alone in the community potentially. What facilitates this is sort of coding Jim as a carer in your notes, and that can pick up then on the problem page on the in Wales, the Welsh Clinical Portal, so the admitting team should know he's a carer. But also in Cardiff, we'd encourage Jim to carry a carer's card, which can be downloaded off our local hospital website. But it could be as simple as a piece of paper in your wallet that says, I am a carer, please ring this number if you find me, and it's a contact number for your next door neighbour, for your daughter, someone who can help mum at home, you know, in the situation where dad's no longer available. So there's an immediate crisis when he gets admitted for his wife for us in primary care. And we're lucky to have the support of the sort of community resource team who try and facilitate, you know, speedy discharge from hospital without readmission. So to try and, you know, maximise physiotherapy and occupational therapy and things that are needed in the home, and trying to keep him out of hospital for readmission because of a sort of social admission, because they're not coping because they can't make meals and things like that. So it's keeping those communication channels open, being vigilant for what else is going on, and just being mindful for what the potential duration of this illness might be, would be my first thoughts. Thank you.
Thanks, Elise. We've covered a lot of ground. And each case really does raise up lots of issues. And of course, when we're talking about these in the abstract as a panel, I think we can all of us think of 101 different variations of Mary and John and Jim, and sometimes it can feel overwhelming. And actually, when you're there with the patient, you know, the course of action usually becomes clear. But I think running through these, there are some themes, and the themes really are relating to, and I've just thought of two which we haven't put on the slide, which when we next do this talk we'll put on the slides. But sort of, this isn't a tick box, you know, this is what we need to do, but the themes running through these three cases have been thinking around mental capacity of the patient for the decision in question. So the mental capacity of the patient is task specific. So people might have mental capacity for some aspects of their care, of their treatment, of their world, but not all. And I think that's something that we do need to remember. Accurate facts. We need accurate facts about progress, prognosis, if possible, allowing for the fact that that's really difficult, as we've talked about elsewhere, and treatment and management options. And if we're not sure, we ring somebody, we email them, and we ask. And sometimes, or quite a lot of the time, unless you've got an emergency such as malignant spinal cord compression from cancer, actually there should be time to ask the questions, get the information, and then put that into the decision-making kind of soup, if you like, the soup of facts that we need to really disentangle. Thinking about what's legally written down, lasting power of attorney involving them, advanced decision for Acute to refuse treatment, any other known written wishes that aren't legally binding but really need to be taken into account. What role has the family got? Those ethical principles, but the scope thing, that Rahm Gillen paper from 1990 something is still really relevant. So we've got the ethical principles that Dafydd was outlining: autonomy, beneficence, non-maleficence, justice, but they apply to everybody individually. There is that scope of the context where they're going. And of course, communication skills, as always, runs through this, not only communication skills with patient and family, but communication skills within our teams and across teams, involving other teams. If somebody's got an out of office on, they are not going to be able to answer your email that day. Little things, it's just setting ourselves realistic expectations. But I think care of the elderly who happen to have cancer, it is a multi-team affair. I think we've demonstrated very ably over the last hour that there's no one discipline that can do this on their own. We need each other's skills and expertise. And that's what we really hope that we've been able to demonstrate today. So what were we going to do? The aims of the session were to highlight complexities of decision-making, to describe some strategies to help decision-making. And I hope very much that that's what you feel that we've been able to do. But as we're winding up, there isn't time to ask you for specific questions. I'm really sorry. I would have loved to have done that. But do please think, has coming to this session really made you think differently? What things will you do differently as a result of attending the session? I'm going to interface more with the Acute Oncology service, which is an area of my practice I'm sure I could use much more effectively than I have. That's one thing that I'm going to do. So what are you going to do? Have a think just before you rejoin the real world. What might you do differently? But do please let us know what we could do to put on more events like this, to perhaps cover more areas of oncogeriatrics, to help everybody's professional development and understanding, and our contact. We've got about 30 seconds to spare, but we'd really like to thank you for joining us today. We hope that this is the start of a new area of our CPD activities, and we'd love to see you again. Handing over to you, Charlotte.
Thanks so much, Fiona, and thanks to the team for a fantastic session. I can see people are having to leave. I can see there was one question which I know you've answered, Elise, that the links to the other community oncology webinars, we'll circulate those to everyone to make sure you can view previous sessions if you weren't able to attend those. But that's all from me. Anything else anybody wants to say before we leave? Nope. Just bye. Thanks so much for the team, and thanks so much for joining us today. Enjoy the rest of your day. Take care. Bye.